Dr. Youmans, thank you so much for joining us here on MD Newsline. Can you please introduce yourself to our audience?
Absolutely. My name is Dr. Quentin Youmans. I'm a heart failure cardiologist here at Northwestern Medicine. Very excited to have a really nice conversation with you today. Thanks for having me.
Yeah. And I know you do a lot of speaking. You're really active in your field. I'm really interested to find out what the most surprising developments in advanced heart failure have been so far that you've noticed.
That's a great question. Advanced heart failure is so exciting because there's so many things that are burgeoning in the field, and so many ways that we can help patients. More recently, we have our guideline-directed medical therapy, sort of our four pillars of GDMT, we call it, in patients with heart failure with reduced ejection fraction. More recently, we're understanding that there are devices that can really bend the curve for patients, so help patients do a lot better. One of the things we need to get better at, though, is implementing those devices. So, for example, patients who have severe mitral regurgitation and they have heart failure with reduced ejection fraction with a dilated left ventricle, we know that if we take a certain subset of those patients and actually do this thing called a clip, so we call it a mitral transcatheter edge-to-edge repair, we can actually help their outcomes. Patients can feel better, their heart function can get better, they can stay out of the hospital. Now that we know that, we have to think, okay, how can we implement it? How do we actually find those patients who are out in the community who have heart failure, who have severe mitral regurgitation, and can benefit from this, but haven't yet benefited? So I think the implementation space is really exciting in heart failure as well.
Yeah, it's just staying on the topic of devices a little bit. I always get excited about new technology, but then the first thing that comes to mind is cost and implementation. So, what's the process with a new device like that when it comes to feasibility of people being able to afford it, insurance coverage? What's been your experience so far?
Absolutely. The nice thing is that thankfully, once they get FDA approved and they have so much data behind them that shows that they're effective, thankfully, most of our patients who are insured can access. But as we know, uninsured and underinsured patient populations are very vulnerable. So how can we make sure that we're helping every patient really access this care? That's really important. And then two, we know that there are patients who aren't even diagnosed with heart failure yet. So they haven't even gotten their foot in the door yet. And then the third thing that we're doing, which is really trying to understand, okay, how can we reach out to our rural populations, for example, recognizing that a lot of these more advanced devices take place at academic medical centers, more in urban scenarios. And so patients may be 2, 3, 4+ hours away from an urban center. So how can we ensure that they actually get access to some of this top of the line or cutting edge device therapies? It's really important.
Yeah, and I'm so glad you mentioned things like access in rural populations. Let's talk a little bit about that. Your work actually describes racial and sex based differences in heart failure outcomes. What nuances are most clinically actionable today?
Absolutely. I think we need to take a really big bird's eye view. And so we need to think more broadly about how can we bring more patients into healthcare in general. So we know that even here in Chicago, unfortunately, there are certain pockets of neighborhoods that have very low life expectancy compared to other pockets. That shouldn't be. And so, one of the things I'm excited about our center, we just recently opened an outpatient site in the Bronzeville neighborhood in Chicago. Very rich neighborhood, a lot of amazing culture. And we're now bringing patients in who historically potentially have not accessed or seen care within that neighborhood. So it's really exciting. So we need to take our care from this major hub, the major academic center, and make sure that we can broaden that out. And that's true for Northwestern Medicine in a lot of different ways. So we're at Palos Hospital. I mean, we have Central DuPage Hospital, all these different hospital centers that are helping care for patients outside of just in Chicago proper, but in the Chicagoland area. So I think taking care to places is really important. The second piece that's really important is making sure that we have a diverse workforce. And what that means is diversity in every sense of the term. Folks come from different places, different backgrounds. They are able to connect with patients in a different way because patients like to connect with people who are like them. Folks come from many different socioeconomic backgrounds, folks who come from many different cultural backgrounds. I think the more diverse our workforce is, the better we're able to care for patients who come from many different places around the world. And, I'm fortunate here to be in Chicago. And so we do have a very rich diversity. And I think we need to care for those patients as best we can. And that does require a very rich and diverse workforce. And then the third and final piece I would say is how can we make it approachable? So, the nice thing about COVID, one of the silver linings with COVID was how we were able to branch out and really use telehealth to help patients access care from afar. I think increasingly we recognize that patients like care in an environment that is familiar and where they can actually get better. Sometimes patients, and there's been a big push for hospital at home. and we're also rolling that out here at Northwestern. But we need to think in terms of our systems. How can we bring, for example, heart failure care? Once we've stabilized them, we know that they have maybe 10 or 20 more pounds of fluid to give and they're in acute decompensated heart failure. Are there ways we can get that patient home so that they're in their own environment, in their bed, still getting excellent care? And I think that way we can also bring more people into the fold.
Very interesting. We talk a lot about health disparities when it comes to heart failures, and I've heard a lot about the health disparities when it comes to racial disparities, but I haven't heard a lot about health disparities when it comes to sex differences. Can you talk about that a little bit? And I'm also really interested kind of in the way that stages of life impact heart health, especially with women. There's been a lot of conversation about things like perimenopause and things like that. So I'm interested to know what those differences are and how some of those life stages that women experience kind of go through that and how it's impacting your work.
Absolutely. I mean, this is a really important question and something that we need to, do a lot of more targeted work towards. We recently wrote this scientific statement around prevention of heart failure, and one of the things we talk about is there's these certain subgroups of patients, including thinking about how there are sex-based differences within heart failure. So I think it's a really important topic. One of the things we know is that throughout the life course, and there's been a lot of studies looking at this. For example, let's take the pregnancy experience, for example. We know that something like preeclampsia is a huge risk factor for cardiovascular disease down the line. The question is, what systems do we have in place to first take care of that patient in the immediate setting? So making sure that they're getting the best optimal care for their preeclampsia while they're going through it. But then also, it's a busy time in life, So let's say hopefully everything goes well in treating the preeclampsia. Baby goes home, family is there, and then things are busy. Back at work, potentially, taking care of and raising a family. And then where does it happen to keep that follow up, keep that preventive action so that patients can do well? I think that's where the system piece comes in, where we need to work with collaboratively with our OB-GYNs and our pediatricians and everyone to say, hey, this is a high risk person. We're going to now bring them into the fold, make sure that they can either get into the women's center versus just getting to a primary care doc. Make sure we're monitoring their blood pressure, making sure that we're monitoring their A1C so that they develop diabetes. How are we treating it? Making sure that we're avoiding things like metabolic disease that can come as we age as well, recognizing that all of these hits, all of these risk factors can build up over time. And so we need to be aggressive about prevention in these patients.
And just thinking about some of those kind of the need for a multidisciplinary approach when it comes to, let's say, pregnant women or women in general. What are some of the comorbidities that you're seeing in that group specifically? And then in general, what are some of the other specialties that you come across, like nephrology, geriatrics, palliative care? How has that kind of multidisciplinary management of complex cases changed the process, or what process kind of helps them work more smoothly?
I think we need to be thinking in a multidisciplinary fashion with every patient that we see. It's really hard, right? Because it can be time consuming. We each have our own siloed goals, our check boxes that we want to get through whenever we're meeting a patient. But particularly with something as complex as cardiovascular disease, we know that there are many different elements that can contribute to disease. One of the more recently described aspects that we're considering is cardiovascular, kidney, and metabolic disease, so CKM syndrome. And it goes through the stages from 0 to 4. What we know about CKM syndrome is that patients who have, for example, chronic kidney disease, they're at high risk for progression and progressing to also develop cardiovascular disease, whether that is heart failure or coronary artery disease. We know that patients who have both are at high risk for having metabolic disease as well. We know that unfortunately obesity is really taking a hold in our country and has been growing at a steady clip for many years. We know that diabetes is also growing. So we think about all of the quote unquote risk factors that are at play. It's often our endocrinologists who are caring for patients in a certain silo. It's often our heart failure cardiologists and our cardiology colleagues that are taking care of patients in a certain silo. And so how do we come together? It's often our nephrologists taking care of patients with chronic kidney disease, but where are the opportunities for us to come together? One of the things that I often do is, I'm taking care of a patient and I want to get them started on Entresto, and they're being taken care of by one of my kidney colleagues as well. I'll often send a message. Hey, I really want this patient to be on SGLT2 inhibitor and I want them on Entresto, for example. How are you comfortable with that? What would you recommend? How should we follow up? So I think even just being proactive about collaborating in care for each individual patient can be really important. And I think one last thing to say is just, I think we're often talking about risk factors, but I also think it's so important for us to shift to cardiovascular health as well. And so, what are the factors that can lead to optimal health and potentially prevent a lot of these downstream issues? And that's where things like the American Heart Association's Life's Essential 8 comes into play. So the 8 things that can really optimize cardiovascular health. And the one that was added from Life Simple 7 that is really important, I love to share with my patients these days, is sleep. People do not recognize how important it is to get that, we say 7 to 9 hours of sleep per night. And it can be really hard. Coming back to the topic of disparities, it can be very hard when people are working, multiple jobs potentially to pay for, for food for their families to get that adequate sleep. But it's something that's very important.
And for our patients listening, how does sleep impact heart health? What's the mechanism there?
Absolutely. So it's sleep is the point where your body heals. Essentially, that's the way to think about it. And one of the things we know about CKM syndrome in general is that it is primarily led by and exacerbated by inflammation. So the best thing you can do is to try to tampen down inflammation, and that you can do that through nutrition. Even when we exercise, we kind of have these micro tears on our muscle that require sleep, that require rest for them to heal. And so sleep is that really important period where you're actually your body's able to regenerate from all the stress that happens throughout the day. So it's very important. And then the other piece I just mentioned is that is also connected to cardiovascular disease and sleep is obstructive sleep apnea. So many patients might have heard of this, but if you're snoring or you're waking up tired throughout the day and fatigued, that's something to consider getting checked for a sleep study. Because that's also associated with and can be connected to obesity. That's also associated with atrial fibrillation and also associated with poorly controlled hypertension and all of these issues that come up in cardiovascular disease. So considering even OSA, adding that into the mix as well.
So the topic of inflammation comes up across specialties all the time, but always feels like kind of the elephant in the room where everything is kind of associated with inflammation. It makes me think of things like oxidative stress and people's propensity towards oxidative stress. Is that something that is brought up with patients at all? Because when I think about oxidative stress specifically, people who are maybe like, for instance, neurodivergent, people who are under a lot of stress in general in different parts of their life, and then that has this cascading effect on different aspects of health.
Mm-hmm.
Are we kind of talking to patients about these underlying mechanisms when we talk about kind of preventative care and understanding their disease at all?
It's a great question. And I think we probably don't do enough of that because to me, whenever I'm talking with patients and trying to help them understand their disease process and particularly trying to optimize their medication regimen, I think the first step is education around why. Because if patients understand why they're given a certain med, then it helps them be motivated to take it, So the next day, the next week, the next month, when they're thinking, everything is so busy, do I need to take this again? Or, especially with the cost. I mean, this is costing me a lot of money. Is it really worth it? I think for patients to understand that it is really worth it, they should understand the underlying mechanism and why it's happening and why we're giving it, why we're prescribing it. So for cardiovascular disease, a lot of it, and particularly in heart failure, a lot of it is driven by sympathetic nervous system overactivation. And so what are the things we can do to try to tampen that down? So when we talk about guideline-directed medical therapy, GDMT, a lot of those are blocking a lot of the hormonal aspects of the sympathetic nervous system and therefore decreasing the fibrosis and the scarring that happens with all of the excess inflammation. And so often when I'm talking to patients about the big four, the guideline-directed medical therapy, the why we're doing this, I do go that level deeper. And oftentimes they'll actually come with questions too. I mean, this is really awesome because we are in the technology age where folks are not just like, yes, doctor, okay. Folks want to know more. They are asking questions. They want to be informed. And so it really is a duty for us to make sure that patients are informed as well.
Mm-hmm. I'm really excited about where personalized medicine is taking us. I think every single conversation, there's some sort of advancement in how personalized medicine is impacting how we do preventative care and how we do, obviously, individual treatment for what we used to think were, you know, diseases that look similar across races and different genetics, and now we know that they don't. So tell me a little bit about how maybe personalization when it comes to things like maybe biomarkers too are changing things like risk stratification and heart failure, and are there any favorites that are beginning to impact clinical pathways or patient selection for things like device therapy or treatment?
Absolutely. I think the biggest thing in the last, 5 to 10 years in terms of the heart failure space was just considering how important that biomarker, the BNP, is, the B type natriuretic peptide. So using that in our clinical practice has been really helpful, and not just checking it on admission, but also hoping to see that come down. So, increasingly we're using the discharge BNP. So after we think they're completely decongested, okay, now let's see where they are now. So we kind of have a new baseline. And so obviously we love to see that having been downtrended. But I think in addition to that, I think personalization also takes a few different steps, a few different lenses through which I would look at it. The first is right now we say everybody gets this, for the most part for HFrEF. Thankfully, we have treatments that are very effective. But I think the future will be understanding increasingly what's the biology of the patient that's in front of me. And is it true that they need all four, or might they need three of these and one of additional, So I do think that there's more work being done and to be done to understand exactly which patient will benefit the most from each. I think the other big piece that we shouldn't forget about personalization is the social milieu or the social environment of the patient who's in front of us. Um, there might be a patient who can pay out of pocket for all their meds. That patient is going to have access. The world is their oyster, essentially. Is going to have access to the best that's possible. But we also need to think and address and first assess what are the barriers to optimal medical therapy for each of the patients that we're seeing, and then tailor our recommendations as best we can to those patients. One of the things that we wrote about last year in the Journal of Cardiac Failure was considering things like interventions earlier in patients who have social need or are vulnerable socially. So, for example, those patients who may not be able to afford all of the components of guideline-directed medical therapy. They may, unfortunately, have a lifestyle where they cannot take those medicines on a regular basis, even despite their best efforts. So are there ways, let's say, for example, if they have severe mitral regurgitation, to consider an intervention that the interventional cardiologist might do earlier or sooner in those patients to help them feel better, to help them stay out of the hospital. And it's only a one-time thing. It's a one-time intervention that can be done on those patients. We have a review article coming out just about all of interventional cardiology and the connection with, or the intersection with, heart failure. And I think there's a lot of opportunity to study that space to make sure that we're taking the best care of patients, but then also hopefully some of those trials, obviously this needs to be studied, but some of those trials will come out positive, and then we can think even outside the box more broadly about how we care for patients, particularly with social need.
So tell me a little bit about just kind of thinking about these patient experiences. We had a really big kind of era of COVID that happened that added to a lot of different factors. Are there any emerging lessons from COVID era kind of research and patient care that have taught us anything about managing heart failure in suppressed or recently infected patients? Has that changed the landscape at all?
Yeah, that's a great question. I think the biggest thing I think is just understanding the underlying etiology of the heart failure. So that's one of the first questions we ask. We have a patient who comes in with heart failure. The biggest thing we want to get at is why, and I think that we've always had that paradigm, but I think increasingly, particularly as we know that COVID, while it was primarily a lung, we know increasingly that it's primarily a vascular condition. And so might patients have COVID myocarditis, for example, or myocarditis from another infection, and how is their vascular system faring after COVID? So I think that was a big shift and a big change. And again, I would come back to how we tend to care for patients in a more effectively remote way actually really changed with COVID as well. I remember during the pandemic, seeing some patients over telemetry, or sorry, over telehealth, and asking them to, like, sit back and kind of pull their phones back so that I could potentially see their jugular venous pressure, or to show their legs. So, while we're in clinic, we would be doing a physical exam, but you can get a lot of helpful information actually over video, over telehealth. And so honing those skills around really optimizing the way that we can evaluate patients from a distance. I think we learned a lot of lessons. We learned that we could do it pretty well. And I think that will just improve our access for patients moving forward.
I'm really interested to find out, just speaking of precision and things like that, what emerging pharmacologic agents or repurposed drugs show promise for things like HF, PEF, beyond guideline directed therapies
Yeah,
this year, if any?
absolutely. I mean, I think the biggest piece is, so thankfully over the last 3 to 4 years, or longer, we've had the SGLT2 inhibitor. So that was sort of that's sort of the beacon of hope, if you will, for HFpEF, which has been really great. We know we have a lot of data with the GLP-1 receptor agonist medications, whether it's tirzepatide or semaglutide, et cetera. Those patients, or we know that those medications can help patients feel better. They can help patients fare better. So we have a lot of trial data that's actually been very helpful in those patients. And then the final piece, or one of the final pieces, is more recently we understand that the nonsteroidal mineralocorticoid receptor antagonist finerenone actually was just recently FDA approved for this patient population as well. So that's in patients with mildly reduced CF and with preserved ejection fraction. And then, so I think that those, in terms of pharmacological therapy, I'm glad we have those, because there was so much time where we really didn't have effective medications. But then the second comment is, and back to this whole like lifestyle and prevention piece, we need to be as proactive as we can about ensuring that we are treating all of the comorbidities that can lead to HFpEF, to hopefully try to avoid that from occurring. And, it's exciting, for example, for the GLP-1s that are helping to bend that curve potentially even for patients with obesity throughout the country and the world even. But I think we need to do even more in that regard.
Interesting. Is there a role for things like combination therapy or sequencing based on biomarker profiles in advanced heart failure management at all?
Yeah, I mean, this whole, sequencing and how to start is a topic of hot debate within heart failure, within our space. For me, it's really exciting because a lot of these medications, most of these they're safe. So the first thing when I'm talking to patients is, that's usually one of the first questions they ask is, what's the side effect profile? Am I going to be okay? And usually my answer is yes. And the other thing, particularly being in a heart failure space, is coming back to collaboration. We work a lot with our pharmacy colleagues as well to make sure that we can optimize medicines at a very quick clip so that they can get the most benefit. So I'm often thinking about simultaneous initiation for patients, whether it's, whether it's 2 or 3 drugs at the same time. And then really it's about those recurrent touch points to make sure that they're doing well. We're checking their vitals, they're checking their labs, their kidney function is stable, their electrolytes still look good, and we're optimizing things as fast as we can, basically. So my target, when I'm meeting a new patient, let's say with heart failure with reduced ejection fraction, is to really get them on good meds with, at least all 4 within a week or so, if not faster, but then optimizing those meds relatively quickly, and then taking another look with an echo a few months down the line to make sure that we're making the progress that we expect.
Hmm. And how has ambulatory PA monitoring affected long-term clinical outcomes in your experience with maybe some of your research or patients that you've seen?
Absolutely. Yeah. I think that's a really exciting space. Remote monitoring is another piece where we can see a patient in clinic. They may go 3 hours away and we can know exactly what their PA pressures are, for example, their PA diastolic, notably. So I think remote monitoring is really helpful, and that requires a system, right? And a collaboration with not just the physicians, but all the clinicians who might take care of these patients. I think building it into our system of care is really important. So, we work alongside our APP colleagues, for example. We have a great one here who essentially runs our CardioMEMS program, which has been great. We can identify those patients very early who need, before they even have obviously overt congestion, who might need changes in their medications. increasingly we're recognizing that not just is it about decongestion, but it's also about optimizing the other aspects of their medical therapy, including their guideline-directed medical therapy, if that PAD is high, and that can actually bring down the PA pressures and make patients feel better, hopefully avoid hospitalization. So I think that the remote monitoring space is huge, and and it's growing, which is also very exciting.
Very interesting. And what guidelines do you use when choosing things like intraarterial shunt devices or advanced hemodynamic monitoring for HFpEF patients? And what are some of the results that you've seen when using these?
Yeah, absolutely. In terms of guidelines, I mean, I think increasingly, or still, I would say that these are very patient-specific aspects to consider, particularly in the devices that you mentioned. I think that again, this comes back to this multidisciplinary aspect. So, as a heart failure cardiologist, if I have someone who I'm thinking may benefit from this, and I'm generally assessing their hemodynamics, I'm generally pulling in our colleagues in interventional cardiology so that they can so that we can together understand like how likely is this to benefit the patient, how feasible is it from an anatomic perspective, et cetera. And then the nice thing about heart failure cardiology as well is that we work so closely with our surgeon colleagues too, so our cardiothoracic surgeons actually getting their input and buy-in about what anatomic issues might be there so that we can make the best determination for each patient. In terms of the guidelines, I still look at, look to our heart failure guidelines to help guide us. I'm grateful for the fact that we also have expert consensus documents that come out on a regular clip as well, on a periodic basis, to help update all of us as clinicians to the best practices moving forward. And I think that but the device therapy specifically had to be very tailored to each patient.
I'm super excited about just the future of care in general. When it comes to how you and your colleagues are preparing for the future of things like disruptive therapies, like cell therapy, gene therapy, things like that, what ethical or access concerns should the physicians be thinking about as they kind of approach this new horizon?
This is really important. I mean, I think the one of the biggest things is making sure that we have diversity in our clinical trials to make sure that any benefit that we see from whatever the intervention might be, whether it's a medical device, et cetera, that we know that or have a good sense that it's going to help in all of our patient populations. And so, and again, I mean diversity in every sense of the word. That's something that is hard to do, and that clearly a lot of thoughtful folks have thought a lot about to do. But I think we could just have to continue to push the envelope in terms of doing better with that. The second piece is once they're out, oftentimes a new and effective intervention is very costly. So thinking about ways as we develop new medications, new drugs, thinking about ways that we can ensure that every patient or every person really can have access to them if they need it. And so I think if we think about it and try to make plans for it and try to devise systems for it up front, then we're in a better place once the medication generally comes out afterwards.
And just thinking about research in general, are there any ongoing trials or areas of research focus that you're most excited about for solving unanswered clinical problems in advanced heart failure or transplantation?
That's a great question. One of the biggest challenges with advanced heart failure and thinking about the heart transplant space is that we know that there's a stagnant number of organs that come available for patients. And so, how can we increase the number of organs that patients may benefit from? I think that's one of the best things that we can think about. And so there's a lot of exciting work being done and research around, for example, higher risk donors, for example. Thankfully, a lot of these are safe. How can we use devices like the Transmedics device to transport organs from a farther distance to help to get to patients? Xenotransplantation. I mean, there have been a number of really interesting cases, and we're continuing to push the envelope there. I think transplant is a really wonderful intervention that we have for patients, but we just know that there's always going to be that cap. And so, how can we expand the donor pool? How can we expand access for patients who need it? And then on the LVAD side, right now, in terms of left ventricular assist device, we just have one device, the HeartMate 3. It's a great device. It really has pushed the field forward. But just thinking about how can we move that space forward as well, and listening to patients every day. One of the things they say is, this drive line is really annoying. So the drive line actually comes out of the stomach and it goes to these battery packs that are pretty heavy that patients have to carry. And so thankfully they're feeling better, they're living their lives, they're working out, but they still have these things that can be cumbersome for their lifestyle. So How can we push the field forward with the LVAD in the LVAD space to make sure that it's fully implantable, for example, and have ways that we can power the LVAD that don't require these like heavy battery packs that might impact the patient's life. So I think those would be the two heart replacement therapy realms that I think would make a big difference for patients.
Wonderful. And just to close us off, what are some last words that you would leave with patients specifically? What do you wish that they knew? What are some misconceptions? Could be anything that you wish that more patients were aware of.
I really appreciate that question. One of the things that I'm very sensitive to is just trust in medicine, and I think that, especially in today's world, there can be an echo chamber, and folks can understandably get lost in what's in the internet, et cetera. I think one of the biggest messages is that we're here for you. We really are. We do want to do the best for each of the patients that we see, and it's also a conversation. So the one of the things I tell my patients often is, I'm listening. I want to hear what you're bringing to the table, and I want us to have a dialogue together about what we think together is the best next step. There's this great book called Getting to Yes, and it's kind of about like negotiation. And one of the challenges we have is that I think sometimes it can feel like we're at odds. I want you to take these meds, and then the patient is worried about something totally different. How can we be thinking about the same things? How can we be looking at a problem together to try to solve it? And I think in medicine, in general, that's a space that we need to transition to so that we take the best care of patients in a collaborative fashion.
Wonderful. Well, this has been a great conversation. Thank you so much for joining us on MD Newsline.
It's been great. Thank you.